Good afternoon, everybody. I hope you had a great weekend. Dr. Michael Jacobs here at the Fertility and IVF Center of Miami. And we're doing our afternoon Instagram live session. Today's talk is preconceptual genetic testing, everything you wanted to know. And when most people think of genetic testing when pregnant, they're usually thinking about the testing that's done once you're already pregnant. And for those of you who have friends or have talked to your parents or have given birth before, when you're pregnant, your obstetrician will talk to you about the risk of genetic testing based on your age. And particularly in women 35 and older, it's recommended to do genetic testing of the pregnancy of the fetal tissue with prenatal genetic testing. This is once you're already pregnant. And that testing is specifically guided to look to make sure that you have a healthy baby from the standpoint of correct number of chromosomes being present. Most commonly, you're just trying to avoid the fact that you want to find out if you have a Down syndrome baby or other chromosomal abnormality. And the risk of a live-born Down syndrome baby, which is an extra chromosome 21, will vary by maternal age. At age 35, it's about 1 in 350. At age 40, it's about 1 in 100. At age 45, it's about 1 in 30. So from a practical standpoint, any pregnant patient, particularly 35 and above, should have genetic testing to make sure the baby is healthy. The simplest way to do that is with a blood test. At about 8 to 11 weeks of pregnancy, they look for what's called cell-free fetal DNA floating around your bloodstream, and they can test to see if there's, with 98% accuracy, whether you probably have a healthy baby or not. That's usually confirmed with ultrasound, and in cases of questions, then traditional testing with amniocentesis or corneal villus sampling can be performed. So what tests can be done before you're pregnant? Obviously, if you're not pregnant with a baby yet, there's no way to tell if the baby's healthy because the baby hasn't been conceived. So we're unable to test to see if you're going to have a healthy baby by testing either parent. If one is doing in vitro fertilization, we do have the added benefits of being able to do what's called PreImplantation genetic testing of embryos, or PGT. And those of you who are undergoing in vitro fertilization, or those that have had abnormalities in the past and are very concerned about having a child that's abnormal, we can actually biopsy the placental cells around the embryo before it's transferred. And with preimplantation genetic testing, we can assess whether the embryo has the correct number of chromosomes before choosing that embryo to transfer. So in this case, we're using genetic testing as a screening device to be able to select out what embryos are genetically normal and what embryos are not. And these embryos form, in essence, you have a normal egg and a normal sperm. They get together, they start dividing, and a certain percentage of embryos that form, when they start dividing, the division process is abnormal and they get a mixed up embryo with the wrong number of chromosomes. And this is a natural event. This occurs spontaneously in people getting pregnant on their own. It occurs in vitro when you do in vitro fertilization. And to some degree, age dependent. If you look at embryos that form in somebody who's under age 30, 70% of the embryos, if you biopsy them, are going to be normal. But if you look at women age 40, it'll be the opposite. 30% will be normal and 70% will be abnormal. So it gives us a way to select which embryo is most likely to work. What happens when an abnormal embryo occurs spontaneously with conception, or an abnormal embryo forms in vitro, if you were to put that embryo back because you did not do genetic testing or you got pregnant spontaneously, abnormal embryos tend to either not continue to grow, so they don't stick and you just get a period or a negative pregnancy test, or if they do stick, they'll tend to miscarry, and the rare one will turn out to be a Down's baby or some other abnormality that can result in an abnormal live birth. The other kind of genetic testing that can be done preconceptual is even before the fertilization of the egg or the sperm. And this is, we call it PreCycle genetic screening. Some people will call it genetic compatibility screening. In essence, if you're normal, you don't have any diseases. If you have sickle cell disease or cystic fibrosis or muscular dystrophy or any of hundreds of diseases, by the time you're in the reproductive age group, most of the time these diseases would have presented themselves and you would know you have a problem. So what we are looking for before a couple even plans a pregnancy is to see whether there's any hidden diseases present. By hidden disease, we're talking biologically about what's called a recessive disorder. It means that you have a mutation, an abnormality on one of your chromosomes, but because you have two copies of each chromosome, and you got one from mom and one from dad, in order to have the disease itself, you need two abnormal chromosomes. If you only have one, then the normal chromosome will compensate for it, and you basically don't have any symptoms and you're normal. But when you go to have a child, you have a 50% chance of passing that abnormal chromosome to a child. So let's say you're a carrier for cystic fibrosis. You have no symptoms at all, not a problem at all. You go to have a child, normally half of those children are going to have the cystic fibrosis gene, and half of them are not going to have the cystic fibrosis gene. And that's not a problem as long as the other chromosome that they get from your partner is a normal chromosome. Because if you have two abnormal chromosomes that both have the cystic fibrosis gene present, then the baby's going to be affected. Now, again, if you're normal and your partner is normal, then the worst either of you could be is both being carriers. And if you're both the carriers of the disease and you were to try and have a baby, you'd have a 1 in 4 chance of having an abnormal child. So it's very important to know this. And what most people do is they get pregnant on their own. They show up at their obstetrician's office, and one of the first tests the OB does is this blood test for a genetic panel to see if there are any risk factors that they need to be concerned with for the baby. And if there are, they will either test your husband or wife, or whatever the situation may be, but certainly the embryo would need to be tested. And you can test an embryo for a specific abnormality. The problem is you can't do it with blood testing of the mother at 8 or 10 weeks of pregnancy. That's going to require either testing directly with cornea and villus sampling or with cornea and villus sampling or with amniocentesis. So what we're trying to do is to assess that prior to getting pregnant, because if you're a carrier for, let's say, cystic fibrosis, and then you find out your husband's a carrier for cystic fibrosis, but you're already pregnant, now we've got this dilemma. You've got a 1 in 4 chance that the baby's got a problem. You can't even find out until the 12th week of pregnancy with a cornea villus sampling, or the 16th week with amniocentesis. And then if you're unlucky and you find out that the baby's affected, then you're stuck in this really difficult position. What am I going to do about this? Am I going to have the baby and know that I'm going to have a very sick child that can live for the next 40 or 50 years perhaps, or it's a worse abnormality where they're going to have die sooner? Or is there something, do I want to terminate a pregnancy? That's a horrible decision to be in. So to try and avoid that, we really recommend that all couples get screened preconceptually, meaning before getting pregnant, with one of these panels of tests to check to see if you're carrying a gene from one of 283 different diseases. In essence, there are 5 or 6 different panels that are done by different companies. They're all fairly similar. They all cover sort of the big 20 that are the most common. And then The next batch they vary from one to the other because we're all proprietary tests basically. But in general, they usually, whether it's Council, Horizon, Progenesis, or the one we use is Sema4, they're all guided to the same thing. They're a screening test to see whether you're carrying a hidden gene for one of 283 different diseases. If your partner is also carrying the same abnormality, then you have a potential problem, and you need to know about that, particularly if you're already pregnant. And in our case, it's beneficial to know before you're pregnant, because in the situation where we have a husband and wife both carrying an abnormal gene, we have the ability to have the genetics lab develop what are called probes. And you can use these probes with an embryo biopsy with IVF to identify which embryos are normal, which embryos are carrying the abnormal gene, and which embryos are abnormal. So obviously, if we had a couple that had a specific abnormality, like sickle cell disease, we would do IVF. If both members of the couple had this abnormality, we'd have probes developed, and then we test the embryos for two things. One, what's called PreImplantation genetic testing for aneuploidy. That's what most of our patients do, to check that they have the correct number of chromosomes present. But in addition to that, in a couple that has a specific genetic abnormality, a specific mutation like sickle cell, we can test the specific embryo to see whether that embryo is affected, a carrier, or disease-free. The affected embryo should not be transferred. The carrier can be transferred because it's no different than mom or dad, and obviously you're doing fine. But more importantly, if we have both embryos that are unaffected as well as embryos that are carriers, even though from a standpoint of the baby having the disease or not, it's the same, if we selectively put back the embryos that are not carriers, that are normal embryos totally, then not only are we making sure that you're having a healthy baby, but we're also eliminating this problem down the road when that child grows up and wants to have another child. Basically, your grandchildren, for instance, have less to worry about because we're eliminating the abnormal gene from the population. A lot of people have had 23andMe tests done. The test we're talking about here, the Sema4 panel, is really a glorified version of that. It doesn't tell you ancestry. It doesn't tell you what country your grandparents came from. It doesn't tell you eye color or hair color. It doesn't tell you if the baby's going to have Down syndrome or not. But it will tell you that you at least have eliminated 283 diseases that are the most common ones that can present in an offspring. So, if we break down genetic testing real simple, before getting pregnant, the genetic tests that we do to make sure that you and your partner are not carrying a hidden mutation that can affect the baby. In some cases with miscarriage, we may do karyotypes specifically on you and your partner to see if there's something that would predispose to miscarriage. But most genetic testing on all of our patients are just for screening purposes. And then you have the test that can be done on the embryos before you put them in. That's called PreImplantation genetic testing. Obviously here the egg and sperm have gotten together, they formed an embryo in vitro, and we can test these embryos for two different things. Most commonly they're tested for aneuploidy to see if they have the correct number of chromosomes. That will tell you if it's a Down syndrome or another abnormality of an embryo you don't want to transfer. And in the couples that have been screened and found to be carrying a mutation, we can check for what's called a single gene mutation defect for any of those 283 different diseases to make sure that it's not present. You can't do them randomly. You can't say, here's a little biopsy check for 283 different things like we do in the blood of the parent. You can only check for the specific abnormality that exists in the parents that they have developed a probe for. And then the last thing is, what if you've not done any of this genetic testing and you're just pregnant? You got pregnant, before any of this happened. The genetic testing there is done specifically to look in your blood at 8 to 10 weeks of pregnancy. This is post-pregnancy genetic testing. with looking for fetal DNA to make sure there's no evidence of a Down syndrome or other chromosomal abnormality. And in cases where there are any questions that still exist, or for verification of a blood test, you can do corneal-villus sampling or amniocentesis, which was sort of the hallmark of genetic testing for the last 50 years, basically. One of the questions is can you have a healthy baby at an advanced age? The answer is certainly yes. Even at age 40, where 1 in 100 live births are Down syndrome, and if you interpret that the opposite way, it means that 99% of the births are not Down syndrome. You just want to make sure you're not one of the ones that's affected. The issues at age 40 are more of the fact that it's harder to get pregnant because a lot of the embryos that form just aren't normal, and as a result of that, there's less chance of an ongoing pregnancy. Do we test for mosaicism, and will we transfer mosaic embryos? Whenever we send genetic testing of embryos, the results can come back either normal or euploid, abnormal or aneuploid, indeterminate, meaning they just didn't get a clear enough signal to tell us the answer. It doesn't mean the embryo is normal or not. And occasionally an embryo will come back with what's called mosaicism. And mosaicism, if you just think of the embryo as containing 50 to 100 cells, and we biopsy an embryo, we'll send 5 to 10 cells to the genetics lab. If they get a mixed message, so that usually if 60% of the embryo, of the cells are abnormal, it's an aneuploid embryo, basically. There are some embryos that come back that are more normal than abnormal, but there's a high concentration of abnormal DNA, and that forms in this gray zone called mosaicism. And the reality of it is, because we're measuring placenta, the dilemma is that those cells represent the whole embryo as a whole. And most of the time it does, but sometimes you form some abnormal cells normally, but the embryos get rid of them and they clean themselves up. So the idea with a mosaic is it really an okay embryo to transfer or not? Nobody really knows the answer to that, and the transfer of mosaic embryos right now is considered experimental. In our center, we do not transfer mosaic embryos. You have to, if you're in an academic center where they have, and you've gone through appropriate genetics counseling, they have an institutional review board protocol for transferring abnormal embryos, including mosaic embryos, then certain mosaic embryos can be considered. It depends what it is. If it's a mosaic for a Down syndrome, I don't think you'll find anybody anywhere that would transfer that embryo. If it's a mosaic for chromosome 15, where we know there's never been a baby born with an extra chromosome 15, that one might be considered to transfer, but most of those are going to miscarry based on our knowledge of embryos that develop to 7 or 8 weeks. So in our center, we're unable to transfer mosaic embryos. There are a couple of academic institutions like NYU and Stanford that have protocols for doing that. How accurate is preembryo genetic testing for aneuploidy? It's 98% accurate, which is pretty damn good. It's not 100%, so theoretically you could miss 1% or 2% either way. And in our own patients, we do recommend, even if you've had PGT-A testing, that you do have at least a maternal blood test for confirmatory evidence that it was done properly, and it's there. You have to realize that both the blood test at 8 weeks that's done, the panoramic test for fetal DNA, as well as corneal-villus sampling, are measuring the same placental cells that we measure when we do embryo biopsy. And the only way to ensure with 100% accuracy that the embryo is what you measure is by doing amniocentesis. Because with amniocentesis, excuse me, you're taking cells that have sloughed off from the baby from the amniotic fluid, and these represent cells of the fetus itself, not cells that are in the placenta. We don't recommend doing pre-implantation genetic testing for people getting pregnant on their own. IVF should not be done just because it exists. It should be done because you have an indication for IVF. But even if you're in your 30s, should you do prenatal genetic testing? This is a matter of personal choice. The recommendation for prenatal testing is for women 35 and above because the incidence of finding a problem is very low. At age 30, the incidence of Down syndrome is probably 1 in 1,000 or less. So it's pretty unusual to find a problem. You can do ultrasound to confirm that there's any suspicion, but it's a matter of personal choice. I can tell you I was an obstetrician. My wife was a pediatric physical therapist. We had our first child, she was 31. We would not have progressed without doing genetic testing, and that was done with amniocentesis back in those days. But it depends on what your feeling is, and because testing can be done by blood tests with prenatal testing, it's so simple, and it's just a matter of, at age 30, it's going to be probably who's going to pay for it. Is insurance going to pay for it? At age 30, maybe not. At age 35, it should. So it's a matter of, is it worth a couple $100 to have that added sleep at night, to know that you don't have anything to worry about? That's an individual choice, up to you. Can you test for trisomy 21, 18, and 13 to determine a normal embryo fetus? Obviously, you've been doing your homework, because all 3 of those chromosomal abnormalities, as well as abnormalities of sex chromosomes, can cause live abnormal babies. Chromosome 13 and 18, those kids unfortunately die within a couple of days. Down syndrome babies can hang around for many, many years. So when you're doing preconceptual testing with the semaphore, you're not testing for any of that. But when you're testing when pregnant, that's exactly what you're testing for. It's an abnormality in any chromosome, not just an abnormality for Down syndrome. We don't find that there's any difference in implantation success. As a matter of fact, I should say that differently. We don't find there's any detrimental effect of doing embryo biopsy on an embryo implanting. If anything, our implantation success rate is higher because we're not transferring embryos that are abnormal. The birth rate per group of embryos is going to be the same, because if you've got 4 embryos and 3 of them are abnormal and 1 of them is normal, and we're transferring 1 embryo at a time, 3 of the 4 times we're not going to be successful at having an ongoing pregnancy, and 1 out of 4 times we are. So out of that group of embryos, only 1 out of 4 worked. If we have 4 embryos and 3 are abnormal, and we discard the 3 abnormal ones and transfer the 1, and that one works, it's the same success rate. The difference is we've done less embryo transfers. So we get a higher success rate per embryo transfer and a higher ongoing pregnancy rate per embryo transfer, because we're not putting back embryos that we know are going to result in miscarriages or failed pregnancies. But even if you put back a normal embryo, its chance of successfully sticking is still going to be in that 55% range. What test do you do for a 41-year-old without IVF? Again, if you're doing IVF, you have the ability to test embryos beforehand. If you're getting pregnant on your own, you don't have that ability. Even if you don't do IVF, there's no way to test the health of the embryo for Down syndrome or a chromosomal numerical abnormality. You either biopsy the embryo, or you do one of the blood tests at 8 or 9 weeks, or you do chorionic villus sampling or amniocentesis. Any of those things will tell you if you have a correct number of embryos there. So at 41, if you're getting pregnant on your own, once you're pregnant, 8 to 10 weeks, get a blood test, check to see if there's anything that suggests the baby has a problem with the correct number of chromosomes. And that's pretty much the story of genetic testing. So in a brief summary, genetic testing for health of the baby falls into two categories. One is the correct number of chromosomes being present. That you have to check for once the embryo has formed with either PGT testing for aneuploidy, or once you're pregnant with blood testing at 8 or 9 weeks, or with Corning Phyllis sampling, which is 12 weeks, or amniocentesis at about 15. The thing that you can do before getting pregnant, whether you need fertility treatment or not, or whether you don't even need it, you just want to know, do I have anything I need to worry about, is to do a genetic preconceptual panel, such as the SEMA4 panel, SEMA4. You can Google it. There are other panels, and that's just looking to see if there's a hidden genetic disease that might, it might not have shown up, but you're carrying an abnormality for it. That doesn't mean you shouldn't get pregnant. It doesn't mean you're not going to have a healthy baby. It just means we have to test your partner before you get pregnant. So in that case, we have the ability to intervene before you even get pregnant. Or if you're already pregnant, you want to get tested to make sure that you're not at risk for a problem. And if you are, then you can do further testing to find out if the baby has a problem or not. And that's pretty much it for today. So, welcome your feedback, your questions, and we're happy to help you. If you have questions further, please contact me or our office or whoever your treating physician is. And wish you a good day, and stay healthy and safe. And we'll work with you to make sure you have a healthy baby as best we can. Have a good day, everybody. Good.